it's always exciting to see how different audiences receive your work. So I'm curious to hear what you think. Okay, so before we get started, I'm really not a fan of this anonymous Zoom space. So I realized that we might not have too much time, but I would like to just invite everyone to briefly say their name and maybe something about their disciplinary upbringing or current interests or something like that. So I have a sense of who's in the room.
Yeah, it's a bit difficult to that everybody is coming, but yeah, you can let them tell who's
Whoever is in the room. So I already met Stefan.
Stefan, right?
Stefan, I can see someone in the institute.
Hello. Yes. From my end, I don't think I can turn the computer in order to see the rest of the. Present myself. My name is Gabriel Stoicu. I'm trained in sociology and philosophy. My PhD is in philosophy with a thesis on cultural anthropology. In my fieldwork was in multinational enterprises, and then I gradually turned to digital anthropology. There are also researchers in cultural anthropology, in organizational anthropology, and also symbolic anthropology.
Right.
So that's
Previously,
Exciting.
you saw Adrian, right? Who is also
yes.
a cultural anthropologist who did his PhD in US and just returned for a couple of years into Romania, working together with Stefan in a lot of projects. And yeah, who's else is there? I mean,
So then I see Edward and Andrea.
right. If you
And
online,
I don't know if they're there. Yeah, online.
and
Maria Magdalena is here. I can see your face.
yeah, you can introduce yourself if you, and you can hear us.
You're muted, I think.
Yeah, you have to unmute a bit. And Erwin was also he's a biologist who did a PhD in our institutes in uh, biological anthropology, medical anthropology. Please, Maria, if you want to present yourself. No, you have to unmute yourself.
Oh,
Oh, isn't
that's
work.
okay. No worries. Okay, well, I have a sort of sense of you all, but I hope we'll get to speak more after I present. One reason for this is that while I present, I can't see your images, so you will have to shout if something goes wrong. I won't be able to see you wave or look weird. Good. Okay, so I thought before I gave the paper that I was thinking to present, I just wanted to say a little bit about what my background is and who I am and how I sort of approach my topic. So I just said to some of the people in the Zoom or the online space that I very much came up in philosophy. Was sort of, I think of it as my upbringing is philosophical. And I do philosophy of medicine, but in the sort of practice strain of philosophy of science. And what I focus on mainly is clinical medicine. So I'm thinking now about some projects that take insights from clinical medicine more into medical research. But my PhD and my postdoc work has so far been very much focused on clinical medicine, and in particular on orthopedic surgery as a sort of case site. But what I'm going to present today is not orthopedic surgery, but it's still clinical medicine. And then I do ethnographic work, and so I go into hospitals, follow doctors around, interview them, and try to make sense of concrete practices, but I do the ethnographic work with an eye to philosophical concept development. Again, what I'm going to present today is not actually based on ethnographic work. So the paper that I'm presenting today is a sort of incidental case that I came across, but I would say that it's still a paper that has this ethnographic sensibility that some philosophers talk about, meaning that it's sort of sensitive to concrete medical practices. And just a brief note on how I think about the relation between ethnography or ethnographic sensibility and philosophy. So I said that I'm primarily concerned with developing concepts and contributing to philosophy, and I think that ethnographic work or sort of these cases that I'm working with are a good way to articulate concepts. And when I talk about articulating concepts, I have in mind what Latour talks about in this paper called How We Talk About the Body, where articulation is the development of something towards becoming better at telling differences and becoming more sensitive to differences and nuances of the world. So he uses this example of an odor kit where we practice becoming better and better at distinguishing closer and closer kinds of odor. And so articulation here, becoming articulate, really is about sort of becoming better at distinguishing nuances. So I think this is generally how I understand what's going on when we expose philosophical concepts to real world practices, is that we make them better able to distinguish nuances and important relevant factors of the world. Right. Okay, so the paper I'm going to present now is a paper that I have submitted, and I got it back with major revisions. So I'm thinking about it, and I would like to discuss it with you after I've presented it. It's submitted for a philosophy journal, so that means that again, like the target is contributions to philosophy, and I've reworked the structure a little bit to make it less sort of targeted towards just a particular philosophical debate and more sort of a general presentation here that might be more interesting for an interdisciplinary crowd. But I'm really curious to hear perspectives both from those of you who are in philosophy and those of you who are more empirically minded. Right. Okay, so let me just set up the general sort of debate that I've been thinking about with this paper, and the question about what's at stake in the paper. So the general debate that I'm thinking about is the question of what medicine aims at. And there's the standard curative thesis, which I don't know that anyone has actually sort of claimed or argued for this, but it's mostly just what we, as philosophers at least, and I think also in our everyday conception of medicine, tend to take the aims of medicine to be, which is curing disease. So recently, Alex Broadbent, who's a philosopher of medicine, pointed out that there is a problem with that conception because there's a lot of things that we're pretty bad at curing. So there are a few things where we're very effective at curing them, but those are things that came about 150 years ago, maybe. So penicillin, sterility, and nutrition things. And really what we've sort of been able to do since then is somewhat minimal. And this has led to a position that Jacob Stegenga, who was here for a while, has argued, which is medical nihilism. So the idea that really medicine is not really doing much for us. And Broadbent think that that's not aligned with what we actually think of medicine. So it seems, maybe to some of us at least, that medicine has done quite a lot of progress since penicillin, and we're still making progress. So we need a different account of what medicine is doing. And Broadbent puts forward this inquiry thesis, which says that medicine is maybe sort of ultimately about curing and by cure he means having reasonably effective interventions. But the primary business of medicine, or what we expect it to do well, is understanding and predicting disease. So we might not be able to cure, but what we think is a successful clinical encounter is when we're able to understand what's going on. So here's a distinction between the sort of aim in terms of what we would like to ultimately achieve, which is cure, and that's fine, Broadbent says, but what we really expect from a medical encounter, if we call it a successful encounter, is understanding. So he has this quote where he says, patients hope for a cure, of course, but they expect a diagnosis, and a doctor who cannot cure them will not necessarily be regarded as incompetent if she can explain to the patient why cure is impossible. So there's this tension between, sort of ultimately we aim at cure, but really what we think successful medicine looks like is not always curing. Now, I broadly agree with Broadbent, and I sort of fall in this latter category of views on medicine. But I think that the views that are articulated that are in the inquiry thesis camp have missed something in terms of what it is that we're attempting to understand, at least in clinical medicine. So maybe not medicine as a big, broad discipline, but in the context of clinical medicine. Right, and to sort of explore or motivate this, I want to tell you about a case that I came across, and I'm framing this as a case prompt rather than a case study. And I do that because I don't think the case is, let's say, rich enough to really be a case study. I don't have enough information about Emily's case. And I also don't think that it single-handedly works as evidence for or against my claim, but I think it's a really enlightening example that can help us think through some of the things that I want to talk about. So that's the sort of motivation for thinking about the case as a prompt, and I'm curious what you think about this way of thinking about empirical material as well. Okay, so I'm going to just read out the description of the case because I spent some time writing it so that you get all the right information in the most concise way. So in January 2022, I was working as an assistant on a research project developing a clinically assisted internet-based self-help program for patients with persistent physical symptoms. And just if you are not familiar with this persistent physical symptoms, it is a sort of label, not a diagnostic label, but that is used for what is also sometimes called unexplained medical symptoms, or something that you might see with patients who have diagnostic categories like fibromyalgia or chronic fatigue syndrome. And it's so persistent physical symptoms are defined as distressing somatic complaints that last several months or more, and where we typically can't resolve them with biomedical intervention. Okay, so I was working with this self-help program for patients with these kinds of symptoms, long-term symptoms, persistent symptoms, physical symptoms. So the program that was developed provides the patient with a range of behavioral management tools, sleep advice, stress advice, exercise and diet, as well as some information videos about systemic or medical theories about sort of body stress response and so on. The program was designed so that it could support individual patients in a modern healthcare system where face-to-face time is very costly. So in order to sort of take some of the time pressure off of the clinical workers, so the general practitioner, and access to the program was given by the general practitioner, who would then leave the patient to do the program for 6 weeks, and then the patient would come back for a face-to-face follow-up session. I was involved when this program was being developed, and my task was to interview patients and clinicians about sort of day-to-day functionality. So does this button work? Do you know where to press now? Is there any blips, fallouts or whatever? So very sort of practical interface interviews. But in one of these interviews with a general practitioner, what was meant to be a very sort of technical tweak interview turned into a discussion about issues of disease management and diagnoses, patient frustration, and doctor time. This conversation and the case, which is the case of Emily, triggered my thoughts on this. So Emily, the patient which the GP had prescribed this program for, was a young woman suffering through many years from severe exhaustion, fatigue, and head and body aches. Prior to being enrolled in this prototype study, Emily had gone through several diagnostic attempts, but with no clear answers. After 6 weeks with the program, the GP had a follow-up consultation with Emily, and the GP told me that Emily reported a reduction in symptoms and a much better balance between illness and lifestyle after these 6 weeks. So general improvement on several counts. Both the doctor and the patient were very happy and satisfied with the process. However, said the GP, when these 20-minute consultation, when the 20-minute follow-up consultation was almost up, Emily said, but what's wrong with me? And this was then followed by additional 20 minutes of much more complicated conversation, while the doctor was being very frustrated that this time was taken from other patients. And I might say that generally in Denmark, you have 10 minutes per patient consultation. So already the first 20 minutes was quite a lot. And adding 20 minutes on top of that is really quite a heavy burden on the medical system. So the conversation revolved around different diagnostic labels: fibromyalgia, I already mentioned, bodily distress syndrome, moderate functional disorder, chronic pain, and other similar diagnoses. But the GP didn't want to give Emily a diagnosis. She explained to me, and as she had done to Emily, that it wouldn't make a difference to give this diagnosis, and committing to one or the other came with a lot of uncertainty and with some controversy. So I then later on talked to Emily again about technical stuff for the program, but Emily also expressed both to me and to the doctor sort of satisfaction with not having received finally a diagnosis, even though she initially expressed this frustration. So there's a question here for me about why Emily might ask for a diagnosis even if she sees improvement without it, and also a question about how we might help Emily without sort of having to give her a diagnosis that we think is inappropriate for one or the other reason. Okay, so that's the sort of case setup. Then I thought I would just say that usually when I tell the story in rooms where there are doctors present, they all nod when they hear that Emily asked what's wrong with me. It's very prevalent that patients ask for diagnoses even when they see improvement without it, or if they're told that they shouldn't worry about whatever symptoms that bring them, they ask for this sort of label. It's so present, in fact, that there's a sociologist of diagnoses who has a chapter in her book on diagnoses called "What's Wrong with Me," and Anne-Marie Judel is her name, and she mentions two different reasons why patients might want to ask for a diagnosis. So she says, when you receive a diagnosis as a patient, it makes your experience of illness legitimate within a scientific medical framework. And then especially she has a chapter on medically unexplained symptoms, where she said, especially in cases where patients feel unacknowledged or undermined, they might request a diagnosis as a sort of political act to challenge sort of medical authority or medical belittlement. There is also another reason, which is that very often we need diagnostic categories outside of medicine, so to get certain benefits or to excuse ourselves from, say, work or child caring responsibilities and so on. So there are lots of reasons why patients might want a diagnosis, even if they can get better without one. But in the case of Emily, I think, interestingly, all of this is already settled. So her doctor very clearly takes her very seriously. She already has all of the social benefits and welfare setup that she needs, and there's no sort of direct reason for her in this encounter to want to challenge the authority of her GP. So instead, I think what is going on with Emily when she asked is not a sort of political act or a legitimacy act. It's rather an epistemic request. Emily would like to know what's going on. She's asking for an explanation or an understanding, and this, you see, is very much in line with sort of this inquiry thesis of medicine. Okay, so usually when we think about the function of diagnoses, we might think that it's a step towards getting a cure. So we think we need to diagnose properly in order to intervene. And this is very much the story that you get in what I talked about before, is the curative view of medicine. So diagnosis is necessary only insofar as it provides the right path towards cure. But in this case, we've seen that Emily sees improvement without diagnoses. So when she asks for a diagnosis, it's for another reason. And here, the inquiry thesis suggests, and I think also the case suggests, that diagnosis here is a tool for understanding disease. Right. So I've mentioned Broadbent, who's a philosopher of medicine. I've mentioned Anne-Marie Judel, who's a sociologist of diagnostic classification. There's another philosopher of medicine, Somerji Varga, who recently wrote a paper about understanding, also falling in this the camp of the inquiry thesis, let's say, the idea that medicine is about understanding. And Varga argues that for clinical understanding, we've tended to focus on biomedical understanding, but really we need two kinds of understanding for clinical understanding, two sub-kinds of understanding, let's say. So the first one is this biomedical understanding, which is about grasping medical conditions in a reasonable level of detail such that we can intervene, understand how intervening on one aspect of the disease might cause different values in other aspects and so on. So sort of something like having a coherence-making theory about what generally collects the symptom into a whole, a coherent whole, the symptoms of the patient into a coherent whole. And this is what he calls phenomenal understanding. So understanding the phenomenon, which is the disease, rather than just understanding symptoms as different sort of aspects of something. And then he says we need to add to this the personal understanding in the clinical encounters. So we need to add understanding of the illness descriptions provided by the patient. We need this because otherwise we're not able to translate these descriptions into biomedical symptoms. So patients might, say, describe their symptoms in ways that aren't, or their experiences in ways that aren't directly translatable into biomedical symptoms. So the doctor needs some cultural context and so on. We also need personal understanding to understand the values and wishes so that we don't transgress patient autonomy or do violence to patient values. And finally, we need personal understanding between patient and doctor in order to understand what kinds of interventions would really be practical or useful. So say something about the kinds of lives that patients live and whether certain interventions are even possible in that kind of life. So Broadbent also has a similar claim that in order for medicine to be useful, we need this body of knowledge of biomedical knowledge, but we also need to be able to sort of connect it with particular patient lives. Now, again, I'm sort of in line with this view of medicine is aimed at understanding, aimed at grasping, getting these coherent theories of what's biomedically going on, and of course respecting patient wishes and having a sense of the cultural background of the patient so that we can understand what they say and think about practical solutions. But I think that this account misses out on something quite important. And I think that this notion of the personal understanding remains very much at the surface level of what it means to be a sick or an ill individual, and sort of mostly, let's say, recruits the personal side of illness in favor of really getting a good biomedical view of the disease that is the main problem and the thing that we want to understand and address. Right. And I think that this is in particularly a problem when we have patients that have no identifiable diseases, patients like Emily. So in the case of Emily, there is no coherent whole, no theory that we can sort of come up with and understand. And that means that even though the doctor can maybe understand Emily's values and understand what would be a practical intervention in Emily's life, they can't really sort of give this the kind of understanding that Barger is talking about as clinical understanding, because there is no coherence-making theory of the symptoms that Emily experiences. So two things happen here. Either we can keep this pursuit of some sort of disease category, we can keep putting Emily through diagnostic tests, develop more disease categories and so on. This has been a very dominant strategy. Some philosophers working on medically unexplained symptoms and persistent physical symptoms are arguing that this is not a fruitful way to keep going. It causes lots of damage to the current patients, and it also seems like it might not be guaranteed that we ever find a particular disease that we can sort of a coherence-making theory. So I want to suggest that instead we, I don't know if take a step back is the right way to say it, but instead of thinking about clinical medicine or biomedical knowledge aimed at understanding diseases or coherent-making theories, we should think about the aim of medicine as that of understanding symptoms. And I think that this is, at least for clinical medicine, a much better way of thinking about it, because diseases are generally labels that we use for generic or generalizable patterns that we see across different populations, and not necessarily about understanding particular or individual instances of illness. And usually what individual instances will have is a variety of different symptoms, and diseases will look different in different individuals. So really in the medical clinical encounter, I think symptoms are in the center of what the doctor is trying to make sense of. Good. So, okay, so I've now agreed with the inquiry thesis. Medicine is about understanding, and clinical medicine, I'm trying to argue, is about not understanding disease, but understanding symptoms and understanding patient symptoms. So here is how we usually think of symptoms in philosophy of medicine, and maybe also, I think, in the sort of intuitive biomedical realm. So symptoms are signs of underlying causes of these symptoms, and there's a whole literature here that distinguishes symptoms and signs. I'm not getting into that. The point is that usually symptoms are seen as some sort of expression of some underlying cause. And even if we don't really know what the underlying causes are, or if we don't have an identifiable disease, we might understand something about the symptoms just from sort of negative knowledge. This is a philosopher called Heine Maung, who's argued that even sort of the absence of a disease can be informative. So for patients where we see a set of symptoms, but we don't necessarily know the causal explanation and we don't know the disease, we might still know that it's definitely not certain causes. So this is what Emily went through with all the diagnostic tests. So she knows that it's definitely not A, B, C, D, and so on. And this might be valuable and relevant knowledge. We also might get some grasp on probabilistic or disjunctive explanations. So something like patients who typically experience fatigue also typically experience these kinds of things, or they will typically need these kinds of interventions and so on. So we have some sort of superficial, say, probabilistic knowledge of population covariation with certain symptoms. And we might also start to get some grasp on, again, sort of covariations, not between symptoms and downstream effects, but between different kinds of symptoms. So say something like low mood, maybe a downstream effect of fatigue, but it might also be the other way around. And when we don't know the cause, it can be rather hard really to know which is causing which. Good. But in the case of Emily again, all of these things actually, so she was given the diagnostic tests before she came into this study that I was part of. And the platform that I spoke about, the online platform that she engaged with in 6 weeks, is exactly designed to give these the 2 and 3 kinds of insights. So it's designed to give you knowledge about probabilistic covariation with the kinds of symptoms you experience and other kinds of effects or things that you can do to alleviate them. And it's designed to explain how different symptoms interact with each other. Now, getting this kind of knowledge seems to have helped Emily. So there seems to have been some progress in her symptoms. And so there was, like I said, a good effect of the intervention. But she still asked for more information. She still asked the doctor, what's wrong with me? And I think that this is because there is still something missing. So Emily had an expectation of medicine that has not been met yet. And I think we can find out what that is by looking towards a quite different domain of illness literature. So this is phenomenology of illness that sees symptoms not as signs of underlying causes, but as insults. So here I'm drawing on work from Harvey Carell and S.K. Toombs, who both live with chronic illnesses. So Carell writes in her book, which is an autobiographical book about becoming ill, the first time I realized I couldn't do something, I felt surprised. It came as an insult, an affirmation of my limited existence. And later on, she writes, the body turns from being a ready-to-hand entity poised to act and immersed in the world to a present at hand that has lost its capacity for intentional action and is suspended from the world. So here she's drawing on work from Heidegger, who talks about objects as being either ready to hand or present at hand. And the famous example of this is the hammer that you see a picture of here. So the hammer is generally seen as ready to hand when it works, and we can use it to hammer nails or whatever. And when it's ready to hand, we don't think about the construction of the hammer, the look of the hammer, the function of it. What we really think about is the nail. Otherwise, we tend to not be very good at hammering. Or we're engaged just generally in the building project, and actually the tools that we're using, insofar as they work well, should not be taking up any attention from our sort of engagement with the world. Conversely, if the hammer breaks, it becomes present at hand. So it becomes something that we need to focus on and something that no longer really makes sense to us as a sort of practical invitation to act in the world. And Carell here is drawing on this distinction to talk about the body as symptomatic. So once we start to get symptoms, the body becomes present at hand, and we start to focus on our body rather than on the world that we live in. So Toombs writes, what is peculiar about bodily objectification in illness is that the apprehension of body as object is such that it renders the experience of uncanniness explicit. So the body's uncanniness, often resulting in a profound sense of alienation from the body. So the body, where it used to be our means of having a world, our means of engaging and doing things in our everyday lives, suddenly become this sort of broken hammer thing that we don't know what to do with anymore. And then finally, Carell notes that, of course, whereas my malfunctioning car or hammer can be sold and a new one bought, my body is me. And so we cannot exchange our bodies. This is an essential feature of our embodied existence that is brought out by illness. So we're sort of bound in with this suddenly alienating object, and we lose basically our means of having a world. So this is the phenomenological description of what symptoms are. Right. So returning to Emily, I think that part of the dissatisfaction that Emily expresses in the follow-up meeting when she asks what's wrong with me is that although the intervention has given her a means of sort of physical improvement, and she has all of this negative knowledge about what she doesn't suffer from and the covariations of the different population level symptoms, is that the intervention that she's been given and the explanation she's been given address maybe some of the dysfunctions or some of these sort of biomedical ideas of the body, but it doesn't address let's say the trauma of bodily alienation. So in the symptom, Emily has experienced this an alienating sense of her own body, and a sense that she's lost the world, the ability to use her body as a means of having a world. And what she's really asking for is something that can address not just the dysfunctions, but actually the alienation. So an explanation or an understanding that her body, not any body in general, but her body in particular, makes sense. And when she goes to the doctor to say, within the inquiry thesis, when she goes to the doctor to understand something, what she's trying to understand is her own particular body, and she's expecting that the doctor will help her see that her body is not alien, but actually can be made sense of. Right. And just to be clear, I think that one very effective way of making sense of things is the kind of biomedical understanding, the coherence-making theory that Vaga talked about. So disease categories and disease knowledge is definitely an important tool, but I think it is not the only tool. And in the case of Emily, we don't have that tool available. And so it's about finding other ways of countering this alienation experience. Okay, so just a few upshots to end on. I think that if we see the epistemic target of clinical medicine as symptoms, so symptoms rather than diseases, in this dual way, not just as underlying causes, but also as insults, we can understand how the healthcare system might be able to help patients who do not have identifiable diseases, and sort of let go of this obsession with finding the diseases. And I also think that we can understand why patients might reasonably feel unsatisfied, even if they have this sort of improvement in dysfunction and negative causal understanding in cases where the insult hasn't been addressed. So in cases where they can't restore their own trust in their bodies. And then just bringing it back to my initial introduction about using ethnography as an articulation tool. I just wanted to say that I think one upshot of starting from the from this case prompt of Emily is that we don't get stuck so much in approaches or disciplines. So one of the upshots of this paper is trying to bring together phenomenology and more analytic style philosophy of medicine, which tend to be quite difficult, but that's maybe a very particular issue to philosophy. Right, so thank you for listening. And then here are some things we can discuss or talk about if you want.
Thank you. Thank you very much. Yeah, I open the Q&A session, and if it's online, then please go on. And if there are people in the room I cannot see, so who's there at the computer to indicate, or as usually they will come to the computer, so because we don't have sound, I mean, you cannot hear quite well if they are in the room. Yes.
So maybe just to say that I'm happy to hear just, so the one thing that the reviewers really pushed me on that I need to think about is what is a symptom and why are symptoms related to particular patients rather than just general categories, same as disease. So if anyone has thoughts on this, I'm very happy to hear that. But I'm also just really curious about general reflections on the case prompt, on this framing of it as a case prompt. And if anyone wants to discuss any of the other stuff that you send out, Richard, so any of the stuff that I've done on ethnographic philosophy or emotions in clinical practice, I'm also very happy to talk about that.
So please go on. If not, I'll start with a short question. If there is, Gabi, I see you. If there are in the room, I could, because we are online here more. We cannot hear you, Gabi, from the where you are.
Yes, I will invite Adrian. He has a question.
Yeah.
Hi, Helena. Sorry for taking so long. I'm dragging one of my legs.
No worries.
It takes a while to walk. But thank you very much. This whole phenomenological take has been quite interesting, seeing the afflicted body as present at hand, right, as alienating it from any form of agency over its function. But I'm thinking about these issues more from a, let's say, anthropology of affect, and perhaps from a political economy standpoint. So don't take it. Don't take it as a comment. They're really questions. So one thing that I found when you were discussing this tension between the curative thesis and the inquiry thesis, right? You mentioned that the inquiry thesis kind of suggests that medicine aims at cure, but what we actually expect to do well is understanding and prediction, right? So it's basically a kind of a semiotic process, right? Let's figure it out and see what we can do. What's interesting in this particular thesis is that there's a lack of mention of anything about the social kind of effective management of distress and fear that, in some perhaps past times, general practitioners were meant to do. And this, you mentioned that the 20-minute consultation, right, and the frustration that a prolongation of this encounter produced among the general practitioners. And this reminded me of an article that I read recently it's an old article, but it's from The Guardian, where it's sort of a personal essay from a general practitioner working for the NHS, in which she claims that the profession has pretty much changed over time. And this is in relation to the kind of political economic changes in the way that we practice healthcare and, of course, welfare. So you said that, in her 30 years as a GP, the profession has horribly eroded. There's a title, right? And she said that she was struck by how detached she ended up being from her patients compared to 30 years ago, right? She started doing this in the this limitation of seeing medicine as basically an inquiry, as an epistemic process, one that's detached from the materiality and the emotionality of the patient relation, might have something to do with how the general political economy of welfare has changed. I'm not sure how this is the case in Denmark, right? But it's pretty obvious in places like the UK or the US, the case of America or Romania, for that matter. So, and then I had another let's say it's speculative, it's a supposition, and perhaps an alternative answer that might be taken into consideration, why Emily, was that her name, Emily, really wanted to know what was wrong with her. Right? So you mentioned, a quest for recognition to render her experience legitimate in scientific terms. Right? You mentioned resistance, right? A way of challenging or recuperating some sort of definitional agency from the medical practitioners. You also mentioned pragmatics, right? Getting out of work, getting a medical leave. But is it possible that this quest for a name, for a category, right, for a diagnosis, might also have something to do with identification in the social sense of the term? So a need for diagnosis may be not only an individual quest for sense making, but can it also be a symptom, a sign, an expression of a need to participate in a broader community of, I don't know, sufferers and of a particular illness? And a name, after all, makes something communicable, makes it intersubjective. It can be talked about, it can bring about empathy and solidarity from others that are outside of the medic-patient relations that you have focused on. So took me longer than I expected, but these are still questions rather than comments. I hope to take them this way.
Right. Thank you. Yeah. So maybe I suppose just to say, like, my starting, I think there's a lot of things that names can do, and one of them is personal semiotic meaning making, and another one is connecting you with other people with the same kind of ailment that you can. I think the thing with Emily's case is that there isn't no name other than the specific physical symptoms, which is very, very broad, very sort of superficial level description, right? So there are a lot of names that we could give her that the general practitioner doesn't find to be right. So like chronic fatigue and stuff like this. So the tension is here. Yeah. So maybe that's to address both of the comments in a similar way. Is that the tension is, what do we do with patients when there is no name that we can give them? Is the best thing to do to keep looking for this name? And that's, I think, very much what's currently happening, is either clinicians keep looking for a name, or they get very frustrated that they're just wasting their time with these patients that have no name. And so why do they keep coming back? Like, what are we going to do with them? And what I really want to do with this paper, so I want to say something about philosophy and sort of criticize this focus on disease in the inquiry thesis, but I also would hope very much that the sort of medical upshot of it is that there is something that medicine can do for patients even when there is no disease category. And this is something that I didn't mention, but there's a small sort of epigraph in the paper about how, of course, diagnostic categories makes the task of understanding symptoms a lot quicker and a lot easier, because it gives you a coherence-making theory. It connects you very easily to other patients who have experienced the same kind of thing. It makes the sort of social communication of your conditions a lot faster. But it isn't necessary. There are other ways of reestablishing the body is understandable, or the body is as non-alien in cases where we do not have these labels. And these are maybe cases where we just need longer time. So when the doctor is frustrated that she needed to spend 20 extra minutes, maybe how she should be thinking about it is that that's just the time that's needed when you don't have a category, and it's not it's because we don't have a category. It might take longer, but it's valuable time spent. It's not frustrating time spent talking about something we don't know what is. It's valuable time spent making sense of symptoms.
But that,
Yeah.
if I may, what renders it invaluable or undervalued? What?
So I think what makes it in the sort of way that I've encountered it in the Danish healthcare system and from this doctor, what makes it invaluable is that there is no. So the doctor is frustrated that there is no category, and this patient is asking for a category, and there is no. Talking to the patient for 20 minutes doesn't give her a category, and somehow everything is oriented towards this diagnostic impulse. I think that we need to know what is the disease, and any sort of time spent just talking without that is seen as a sort of waste of time. I don't know, something like that. I mean, when you talk to the doctor, of course, they can see that it wasn't a waste of time, but the immediate impulse is that because it didn't result in a classification, it was a waste of time. You didn't find the disease. You didn't, so I think there's just a very, that's my sense, and this is again not based on like very thorough empirical work, but my sense is just that there is sort of a saturation of orientation towards disease and diagnostic categories, and that's the sort of what I'm maybe trying to push a little bit against. And not saying I think disease categories are very helpful, but I do think that there are patients that don't have them, and it's a shame when these patients that don't have disease categories become the problem.
Thank you. Yeah. If there are other questions from the room.
Just a second.
Online, you can raise your hand and I could see if there.
No, just a simple question. I want to know if this is a case study or if you interviewed more patients in order to draw conclusions and something like that. This is my question.
Yeah. Yeah, so this is maybe just a comment on the practicalities of how research works. So this was a case that I came across when I was working, as I said, as a research assistant, doing very pragmatic interviews about how online buttons work. So it wasn't even set up as a study. I just very randomly stumbled on this case. And then right after I had this interview, I got another postdoc on a different project. And the case of Emily just sort of kept like it was in my mind somehow. And I read all these articles about the inquiry thesis and some of the other articles that I mentioned, and I got very annoyed with them, and they seemed connected to this case. So really, it's not something that the empirical side is not something that I've dug more into. I don't know how to describe it. It was a prompt that kept being there with me, that then made me annoyed with certain theoretical utterances in the literature. So that's why I call it a case prompt and not a case study, because I don't think that I think it works for me to articulate some pushbacks on some of this theory, but not as evidence. I don't see it as evidence.
Okay. Thank you.
Yeah.
Thank you.
Yeah, I'm really curious what you think, what those of you in the room think about this distinction between case studies and case prompts, and if there's any sort of methodological reflections on this.
Do you want feedback from the room?
Sure. I mean,
If there
anyone
is.
who has ideas.
Do you want to speak something here? In the case studies, I think they should be more put also in a comparative perspective. A case prompt, it's just some like the anamnesis from medical documents, more like recording some data. I will invite another colleague.
Hi.
Hello.
It was highly interesting what you had to present. I was born in a family of doctors, medical doctors, involved in research and also in dealing with patients. And their reasons to be, their reasons of involving themselves in a constant fight with affections, medical affections, was that they were affections. Now, our condition is to be mortal. So there will always be a limit to what doctors, medical doctors can be, and this shouldn't be a frustration. This is the situation. We cannot go outside it. But of course, the fight is the reason. We have to fight in every way to mend, to better our condition, and this is an unending kind of problem. Now, humanity has a history of many thousands years. For many thousands years, there was no scientific medicine. There were practices. There was philosophy or religion to cure people from the point of view of, well, their mind rather than their body. And now it's an extraordinary advantage, the fact that we of medical science. I was curious to know if you tried to assess the number of questions that cannot be answered with respect to the answers the questions that do have an answer and a solution. Because this has to do with the philosophy you're addressing. What is the size of philosophy nowadays in the context in which there are thousands of illnesses that can be cured? And I don't know how many are the problems of the illnesses that do not have a cure. Well, thank you again. It was very interesting.
Thank you. Yeah, so I haven't counted. I don't know, and I don't even know how you would count diseases and cures. And so from the debate on the curative versus the inquiry thesis, there are a lot of examples where most of the cures, the effective cures that we have, are quite sort of momentary discoveries where things converge, and then since then we mostly just sort of vaguely intervene on things, not particularly effectively. But maybe one thing I wanted to say is that for these, this is a debate that's ongoing, and really, I mean, I don't know where it ends up. Maybe it turns out that many of these patients with persistent symptoms actually do have a particular disease that we just haven't conceptualized yet. So I don't know. But what's the current frontline discussion about these persistent symptoms is that the reason we don't have a disease for them is that we're thinking about causes in the wrong way. So we're thinking about we have a very sort of foundationalist view of diseases as having mono causes like infection. And there's a lot of diseases or ailments that we can't make sense of using this theory of disease. So a lot of autoimmune diseases and sort of diabetes and stuff like this are a lot more complex and happen at many different levels. And so when we keep when we try to make sense of persistent physical symptoms in this sort of model from infectious disease, we're just going to keep failing. And so the idea here is something like we've had a very successful account of disease that worked for infectious diseases, but there's a lot of ailments that it doesn't work for, and there's a question about how we should reconceptualize medicine in that view. I don't. Yeah.
Thank you. Stefan would like, right, to please interview.
Yeah. Thank you, Helen. And actually, I have a question. So I'm very far away from what you're doing, but this just popped up in my mind. I was wondering what role the certainty and uncertainty play in your analysis. Let me explain. As humans, we all crave for certainties, yet, especially in the modern world, we live in a very uncertain or surrounded by all sorts of uncertainties. Think of climate change, for instance, or this crazy development of technologies which bring new types of uncertainties. But it's one thing to deal with this kind of global uncertainties because you are not alone. In climate change, it's scary, but it's not just me and you, it's every other human on this planet and even non-humans as well. With diseases, so what you deal with, this is something very individual. So these are your symptoms, your illness, your life. It's nothing you can share the burden with. So I was thinking if you introduce this kind of concepts, what would give you from the perspective of the patient? Because when you ask, you said, what is a symptom? It might replay certainty and uncertainty, especially, may replay somehow to this question, but from the point of view of the patient, not from the point of view of the doctor. So I was thinking, I don't know if it's very clear what I try to ask you, but I think I have the impression that this should be somehow present in your paper and your presentation as well. I don't know if it makes sense. Just think about that.
Yeah, no, thank you. No, I think it makes a lot of sense, and I think it's part of what is sort of inside of this notion of the alienation is the sudden loss of. So hold on. So this first quote from Carell about surprise, and sort of suddenly not being able to do the things. So basically, Carell has a type of slow-growing lung cancer that erodes her tissue in her lungs, and when she starts discovering her symptoms, it's that she can't walk upstairs or walk up a mountain that she used to be able to walk up without any trouble. And so suddenly these things that she never thought about being able to do, walk up the stairs or whatever, walk down the street, she can't do. And that creates this surprise moment, and it feels like her body is attacking her, or like it's an insult to her as an agent. But of course, it's all the more eerie because it comes with a lot of uncertainty about whether other things might stop working as well, right? There's this proliferation potential that suddenly your body doesn't want to do this. Like, how many other things are you going to be unable to do, especially with progressive diseases? So I think it's very much in that phenomenology of illness description is the uncertainty is there as well. And I think So I've been thinking about this. And I think I decided to fall on one side, but I'm not sure that's the right side. So there is a question about whether what is important. If I'm saying one thing that we require from a doctor when we go to a doctor is not just that they can biomedically explain, but it's that they can tell us that our bodies are not weird or alien, that our bodies make sense. And that is a way of unalienating our bodies. And we might think that that's valuable. So the way that I've been thinking about it is that for me to experience my own body as alienating this creates a lot of uncertainty, and it's very unpleasant because it destroys my ability to think of myself as an agent. So what I really need is for someone else to just give me a sense that I can understand, that my body is understandable for my own individual sort of sense of being an agent. But what you're saying is maybe something like, actually what's valuable about that is also that I get a sense that someone else understands my body, that I'm not alone with this uncertainty, that there is someone that I can share this uncertainty with. And I don't know, because then the reason I was thinking about that and sort of thinking about like maybe we could think about the doctor as a coach or something like this, but then I worry that we give too much of the task that we think psychologists have to the doctor. And I'm not sure that that's a good, if we want to require that from doctors. Does that make sense?
Yeah, but it's not just that. I mean, a diagnostic, correct or not, it gives the patient a sort of certainty. Now that I know what I have, I can kind of fight with the right tools against what I know I have. A lack of that, or maybe, that creates even more uncertainty, which would lead finally to alienation and suspended from the world, as Carol says. I'm thinking also to that.
No, so definitely getting a diagnosis is one very quick and effective way to say your body is understandable. We know what's going on. Here's your diagnosis. Right? That's a very efficient way to give this. The problem is that diagnosis has to be sustainable. So if you don't give the right, like you could say that there's a maybe a motivation to give a diagnosis that is more or less right, just to give this certainty, even if it's not completely accurate. But if it's a diagnosis that breaks down as soon as the patient leaves the room, then it's not helpful.
Yeah, it gives you also a possibility to kind of, relate with other people with the same disease, right? So that's the point, in being kind of certain about something, right? Because you can relate to something, whereas uncertainty leaves you, floating. You have nothing to to hang on. So that's kind of the direction of my question. But
no, definitely. Yeah, I think this was also something that Adrian was talking about. Yeah.
Thank you. Other questions?
Not from the room.
I will then try to, if you allow me, the questions. I'm probably the one of the few philosophers there who really did also. I worked on understanding, so it would be a bit targeted on this part. So you have a slide there about when where you had when we do not know, we still understand, right? And you were listing there some 3 entries, right? Negative causal probability and something else, right? I mean, first, of course, that gets gone through the position that understanding is a kind of knowledge or super knowledge or something like that. But still, understanding is grasping something, right? An explanation or something here. It might be that, yeah, you put it in this way. Nevertheless, understanding is gradually, right? It comes in degrees, right? And you might say, okay, I would get some understanding from this, from getting or understanding as a symptom, whatever it means, or from the other symptom. Nevertheless, that might pull in different directions, right? So understanding is also one of the marks is coherence, right? And so it denies you, it would undermine your understanding in this way, right? So you will not gain understanding. You would get some confusion there, right? You will not reach it because you don't reach a coherence, right? Understanding was, or at least coherence is a mark of this. So it is a kind of tension inside this. So another way of putting it, because you also look at the symptoms. I was trying also a view from semiotics, right? The symptoms might be signs of something, right? If you deny that something, so you will grasp signs, but without going all the way of the signification or semiotic process, right? So you deny, you cut that process. So do you have an answer, or how would you go around this issue?
So I think there's a so what Maung is talking about with these three notions of understanding is really negative understanding. So it's understanding what it's not about.
What kind of understanding is this? I mean, is it you grasp a piece of knowledge, of information, of let's